As Steve said, I want to talk to you about what I think is Australia's #1 health challenge in reform. So I want to start off by asking you a question. Can you please put up your hands if you yourself or someone close to you has been affected by mental ill health? Phew, that's great. I mean, it's not great, but that's... And that's the whole point. And I'm going to ask you in a minute whether you'd support a key question here. But the next question I want to ask you, though, is what about young people? How are they travelling? Do you think that they're bursting with health, that they're on the threshold of life, they're looking forward into the future with great optimism? In other words, that mental ill health in young people is just an island of misery in an ocean of happiness? Or do you think it's more like an iceberg, the tip of which we can see, and lurking below the surface there's quite a lot of very significant mental ill health? How many think it's the island? How many think it's the iceberg? Okay, great. Okay, so I'm going to talk to you about some of the things that we need to think about in terms of design, concept and design, and then talk about some real solutions to this problem, which I think are within our grasp. It's the achievable dream that we heard about earlier today. Okay, so this is what we call the burden of ill health, the health burden in society. And you can see after 50, it's all bad news. So we get all these horrible illnesses, cancer, heart disease, dementias, all gloomy. In younger children, there's also a cluster of health problems, illnesses that we really need to respond to in a strong way. And then in this period of life, which some people have thought was just an ocean of happiness, we see that the main health problem for young people, 60% of it is mental ill health and substance use. And we see this surge happening from puberty through to the mid-20s with a peak in the early 20s. 75% of mental ill health appears before the age of 25, and up to 50% of young people will experience a period of mental ill health during this period of life. And it does have real consequences. It's not just the worried well. If you look at young people who have had that experience and follow them up at 30, they're earning less, they've got fewer friends, they're in more trouble, if they're still alive. Many of them will actually die. The biggest killer of people up to the age of 34 in women and up to 44 in men is suicide. So there are real issues to be dealt with here. And yet our health system is incredibly badly designed to respond to this. Look at the access rates. 13% of young men who have a diagnosable mental disorder in any given year get access to any kind of mental health care. And it's a little bit better in young women, but still more than 2/3 of them don't get any help. So this is completely unacceptable. So that's the need. We know that we've got to create something a lot more attractive if we were going to improve on those rates. And the iPhone, it's like Coca-Cola, but it's something that people want. And that's what our mental health care has to feel like for young people. The other feature of it, there are a lot of applications, and they're all in the one place. It's a one-stop shop. You don't have to go to 15 different agencies to get your needs met. And the sort of applications that young people need are not rocket science. They're very simple series of things that are related to their health needs. And that's what I'll come back to in a minute. But it is a question of the right application at the right time to get the right result. One of the other problems we've had in the mental health field is this ambivalence and confusion about diagnosis and what it's for. Now, a diagnosis in healthcare is to help you pick the right kind of help, the right kind of interventions and treatments that actually make a difference and actually will change the course of the illness. And in mental health, I was reading The Economist yesterday, everyone agrees, the mental health professionals, the community, almost everybody agrees that the current diagnostic system isn't much good for that. So we've got to have a newer, simpler, improved version for this. And to do that, we can probably take some lessons from other areas of healthcare and look at this idea of clinical staging. And it also helps us deal with this issue of stigma and labelling, which people are obviously concerned about, labelling problems which we might just want to think about as problems in living or crises in everyday life. We don't want to turn everyone into needing mental health care in that sort of way of labelling. So how do we sort that out? Well, it's actually very similar to what we would do if we were thinking about cancer, whether it was skin cancer or breast cancer. We want to be able to see people when they're concerned about something and actually assess the problem and work out, is it something that just needs a very simple intervention, whether it's reassurance, support, a bit of information, and watchful waiting, or is it something that we want to get onto pretty quickly because it's the first signs of something potentially very serious? And the staging idea lets us do that because we can sort out what are benign conditions from what are potentially serious and disabling or even lethal conditions. So these blobs at the left here, that's meant to be that zone of uncertainty where we want people to actually seek help and talk to people and share the issue, and then it can be sorted out. And we actually are learning how to predict, the risk of progression from one stage to the next, and also very positively developing ways of reducing the risk of progression across these stages. So as you can see, these are some of the diagnoses or the syndromes that we actually see in young people during this period of life, and they're really syndromes, and they can wax and wane, and they kind of settle into something that we can recognise as a more classical sort of mental health problem, mental illness further down the track. But if you want to pick people up at the first signs of trouble or the first time that they might be able to benefit from help, and it might be a simple intervention, we have to go earlier. The need for care, the need for some kind of helpful intervention is much earlier than the point at which you can apply these very crude and unwieldy diagnoses. And that's one of the points of the staging model. The other issue about it is that just like in more clear-cut medical illnesses, there are biomarkers these days to help us, and whether they're peripheral biomarkers or biomarkers related to the brain, in this case the hippocampus, which is the part of the brain associated with memory. We know that the loss of volume of the hippocampus and apparently some kind of damage to it does actually occur in many mental health conditions, in depression, in post-traumatic stress, in schizophrenia. We see this loss of volume of the hippocampus on brain imaging, and so we know it's got something to do with progression across stages of these illnesses. And yet it's not specific to any one particular illness. So it is another validator of stage and another thing we could use to support our diagnostic system and also different treatments. Okay, now that's some of the design tools, some of the thinking that we need to work on and guide us in a new 21st century way of approaching it. So where do we start in terms of help? Well, we've heard a lot about empowerment, and this is one of the first things. We start with the community and we try to help the community to own the problem, understand the problem, share the problem, talk to each other about the problem, and also respond so that instead of someone who's distressed or in real trouble, and we find people around them turning away in confusion or in uncertainty. Mental health first aid, developed by my colleagues in Melbourne, Tony Jorm, Betty Kitchener. This is a way of teaching people basic skills whereby they can actually respond as a lay person, but in a helpful way, in a helpful way to that person. The next thing is the one-stop shop. So this is the youth-friendly environment that attracts young people and makes them feel comfortable. They've had a hand in designing it. And this is the headspace concept, which is now in 30 places around this country. And it's actually solved that problem of engagement. So young people will actually seek help here, many of them, and 93% are satisfied with this kind of ambience and this sort of cultural approach. And so it's not just a youth drop-in centre, though. It's actually a place where this real expertise, these applications are on hand, the youth-friendly GPs, the psychologists, the drug and alcohol workers, the vocational and educational experts. As you can see, it's not rocket science. These are the things that young people need to recover from these episodes of mental ill health, and also remain in or return to normal life and stay on that trajectory which they're on in terms of this absolutely exquisitely sensitive period of development, the transition from childhood to adulthood, very, very sensitive. If mental ill health does strike during this period, then the scaffolding around the young person is very, very sensitive to that. So we've got to make sure it's really in place and we minimise the social damage to those young people and avoid stigma. These are stigma-free settings. If you've been to one, you'll know what I'm talking about. It feels very, very different from the standard clinical or mental health settings. And that's a vital thing. PACE Clinic, this is another area which is incredibly exciting actually in mental health care, because years ago when I trained in psychiatry, the whole idea about psychoses and schizophrenia was that you couldn't recover from them. They were like a psychological death sentence. But what we've been able to show is not only we can identify young people who are at greatly increased risk of developing these illnesses, 400 times greater risk. We've got a definition now which will recognise a young person who's already in trouble. They've already got symptoms of various kinds, but we know that if we don't do anything, they will have a 400 times greater risk than the general public of developing a psychotic episode. And we set up structures like this, which are again stigma-free, and look at different ways of reducing that risk, and we can reduce it. There are at least half a dozen studies now which will at least halve the risk and maybe reduce it even further, at least while we're offering different interventions. And they're a range of interventions, and obviously we want to pick the safest ones. So we go for support, cognitive behaviour therapy is the first cabs off the rank, and then if that's not working and the risk is progressing, then obviously we think about other things after that. But it's basically a risk-benefit ratio decision. We're trying to make sure that we're not doing any harm first, and we're obviously trying to reduce the risk. And this is a major change. If you had told people 20 years ago this was going to be possible, they wouldn't have believed you. So it is a very big change. And it's a principle which can be applied across the board in youth mental health to a range of other disorders. And this is what we've done, I suppose, with other constructions of models of care and different types of interventions. We developed a model called EPIC, which is about early psychosis. But there are other foci that we're actually bringing on stream now in a kind of EPIC plus type way of thinking. And this is really on the policy agenda nationally to make these sort of approaches available to all young Australians, not just a handful as at present. These interventions and these packages of care, provided they're offered for the early years of illness, do actually change the course. They do actually improve recovery rates so that we can actually see very good outcomes. I can tell you a story about a young man who we treated about 10 years ago in EPIC, who is now a second-year medical student in the University of Queensland. Now, that would not have happened without this early intervention sort of model and this vocationally focused recovery process. And the vast majority of people in Australia do not get access to this kind of available expertise at this moment. A key feature is youth participation, and as well as us putting ourselves in their shoes, it's good for the young people to put themselves in our shoes and help us with the task. And that's what this is about. Young people being involved in peer support, in delivering these programs, in designing the features of the model and the culture of care, and giving it the right environment so it does feel like it's something a product that people actually want, as well as actually that it will help them. So young people's role is absolutely vital in both the headspace and the EPIC and the broader youth mental health sort of focus. Similarly, families. The families very often, or nearly always, are the best scaffolding the young person has in making this transition to adulthood. And they obviously have to adapt. The scaffolding has to adapt, and the families have to really be supported because they go through tremendous stress. You can imagine it when their teenage son or daughter becomes depressed or even psychotic. And particularly if there's a need for ongoing mental health care. It's a big crisis for the family, for the siblings, and they need to be involved and supported too. And there's a role for them to help other families as well, and also through a peer support sort of mechanism. So these are modern ways, 21st century ways of providing care, which again don't rely on massive technology or brilliant new breakthroughs in drug therapies. They're actually common sense, but we're still not doing it. Home-based treatment. Now this is an incredibly good way to work. It's a way of avoiding the upheaval of hospitalisation, even in very acute situations where there's a fair bit of risk. It is possible to look after young people in their homes, with their families, provided there's enough intensive support around the clock for these young people. So this is something I've had personal experience with. It's a great way to work, very, very satisfying, and I think the families and the young people really appreciate it as well. And it's very often possible, but again, something that needs investment and commitment to actually make it happen. Recovery. Obviously, we're not just interested in just a narrow medical or clinical approach. We know that we can get the vast majority of young people better in a symptomatic way, whether it's depression or psychosis or anything else. But our social recovery rates, in terms of return to work, return to education, are only about 50% unless we do something extra, which is vocational recovery. And with these more modern vocational recovery programs, we know that we can get about 85% of young people, even with very severe forms of mental ill health, back to school or work. Again, it's looking at the big picture in a holistic way and looking at the life course. We're trying to imagine that life at 30, and that's what we're aiming for. We're not just a band-aid or an episode-related sort of approach. We want to make sure the whole life course is sustained. Now, obviously, what I've tried to convey is a sense of real competence, optimism, and capacity. And we have developed these things in Australia, these early intervention strategies, these youth models of care. It's a global problem. It's in every developed country, this issue. But Australia is actually contributing to innovative 21st century systems and models of care. And we want to see them made available to all Australians. And that is really the first challenge that we have to face. How do we convince the community and how do we convince our political leaders to invest in this and ensure that we get the same access and quality to care that we see in the physical health system? We constantly see new investment into cancer, heart disease, all the other acute areas of the health system, and this area is always the last cab off the rank. Now, I just ask you the question, are you going to tolerate that? How long are we going to tolerate that as a country when we know there are solutions which everyone's children, everyone's family can have access to? So that's a rhetorical question for you. I think, obviously, because it's still a building area, we do want to see new and better ways of working. We want to discover new ways of working both in a psychological way, in a social way, and also we do need new neuroprotective and therapeutic ways of working in a sense of medicines as well. There's a lot more work to be done. There's a whole professional field to be created, and there's a whole community to involve in the care of our young people so they can make a successful transition in very big numbers to that next stage of life, and so that it will be much smaller problem than it is currently. So I would really like your help and support and right across the Australian society for this challenge. I imagine in another 10 years this could be completely transformed if we get that support. So thanks very much.